بسم الله الرحمن الرحيم. الزملاء والزميلات، السلام عليكم ورحمة الله وبركاته. أسعد الله نهاركم. Today, inshallah, we are going to deal with the topic as you see here, controlling or management of renal function in diabetes. This lecture is summarization of the topic from the textbook based on European guidelines, because the vital parameters are a little bit differences between the European and American ones, a little bit differences. Both are right. The graphs and tables are copied without change, including the references also from European guidelines. Our lecture, inshallah, will include the importance of maintaining good renal function in diabetes, as this category of patients are very vulnerable to lose their function test because the multi-organ compromisation and the nature of disease itself. Here we are going to come through importance of diabetic kidney disease. We are going to talk a little bit about unmet need in management of diabetic kidney disease, and here we are going to focus on two new medications introduced in 2019, which proved to be successful in managing and protecting people with diabetes, heart and kidney function. We are going to talk about potential mechanism of nephroprotection, including old and new guidelines. We are going to come through concepts of pump, pipes, and filter, which is the new pathway for the new introduced medication. And then we are concluding with take-home messages. We are going to start with this graphs. This study showing that number of people will end by end-stage renal disease since 2010, and going through are going to double. Number is double actually. And unfortunately, the greatest portion is in Asia, which is almost 2 million by 2030. Guidelines incriminate lifestyle and type of food, type of mobility, and all these things are incriminated as causes for this increased rate and doubling of figures throughout the years. So in Asia, almost in 2030, this is going to about 2 million people will end with end-stage renal disease. That's why the topic is so important and need to be dealt with in careful way. Here, dialysis survival component compared to common cancers, we would like just to illustrate that the danger of diabetes in kidney function and heart function. As you saw from the announce of the lecture, we have a nice picture that illustrates the hemoglobin A1C in the right, which is the main factor coincide with cardiovascular disease. And in the left side, there is the blood pressure, which is going with renal function. Controlling of these two agents, hemoglobin A1C and blood pressure in diabetic patient, are fundamental and will affect his life expectancy, prognosis, complication of diabetes, and will affect everything. So here, as you see, this comparison between women and men, there is no big differences, but unfortunately, the survival probability is almost 30%, as you see here in the yellow line. These are people in dialysis or those who lost their kidney functions. Even it's lower than colorectal cancer and prostate and breast cancer. So the kidney function maintaining in diabetic patient is so important, so as not to reach this era. Here, worldwide diabetes is responsible for 51% of end-stage renal disease. Hypertension coming in the second one. All other causes are responsible for 31% of end-stage renal disease in diabetic or non-diabetic causes. Other causes of loss of kidney disease are including nephrotoxicity, drugs, dye-based examination or tests like contrast CT and contrast MRI, and traumatic causes. But diabetes here are the incriminate one, or the great proportion who are responsible for losing kidney function in majority of patients here. So it's so important to deal with this topic. Again, here is the life expectancy among people with diabetes, comparing men and women. Always diabetic kidney disease shorten lifespan by 16 years. And this is too much time. This is too much time, almost 1/3 of life expectancy for human. So careful dealt and maintaining of drug and preventing complication in this era is so important. This graph or table illustrating patients with chronic kidney disease and type 2 diabetes are higher risk of all-cause mortality, even with multifactorial risk control. This graph and study is based on the risk factors, which are showed here in the green color, are hemoglobin A1C, blood pressure, total cholesterol, and smoking cessation. As much we control these factors, as much we have low mortality rate. As you see here, from your right in the screen, this is 0 or 1 factor controlled, is going with high mortality rate, as you see here in both sides. And as well, we control the factors. If we control 2 factors, mortality rate will decreases. As we control 3 factors, more decreases occur. And if we control 4 factors, we will maintain good life expectancy and low mortality rate. These risk factors, as I illustrate in the beginning of the lecture, hemoglobin A1C, there is slight differences between guidelines, European guidelines and American guidelines. American guidelines are a little bit strict. For example, hemoglobin A1C in American guidelines is supposed to be 6.5. Here is 7%. Blood pressure in American guidelines are 120/80, the normal one. And like these differences, which is not a big issue. But as much we control these factors, we will maintain good mortality rate and low complications. Here we are going to shift into another objectives of our lecture. We have certain definitions and terms used in nephrologist and nephrology department, which is end-stage kidney disease. And this is chronic dialysis for more than 30 days, or kidney transplantation, or estimated GFR less than 15 millimeter per minute per meter square, sustained for more than 30 days by central laboratory assessment. All these are termed end-stage kidney disease, one or either. Doubling of serum creatinine. This is doubling from baseline average sustained more than 30 days by central laboratory assessment. We have renal death, and this is mean this in patients who have reached end-stage kidney disease who died prior to initiation renal replacement therapy, and no other cause of death is adjudicated or identified. In this era, guidelines are speaking about several medications used to treat diabetes and complication expected to occur in spite of using this medication. We are talking, we know that we are controlling type 1 diabetes with insulin, basal bolus. We are using another hypoglycemic agents like metformin, like gliclazide, and so on. But all of these have some side effects, which is to some extent not acceptable in some patients, certain patients. Insulin is going with obesity, is going with hypoglycemic attacks, is going with other diabetic complications of lipid complication, lipid accumulation, and so on. Increase triglyceridemia. Metformin have also catastrophic side effects like lactic acidosis, and it's to some extent not recommended in acute and chronic kidney disease, and as well the other agents. Here today, inshallah, we are going to talk about two new agents that are cardioprotective, renal protective, and good outcome in issue of mortality and morbidity in diabetic patients. These are SGLT drugs, which is our sodium glucose co-transport inhibitors. This new drug introduced into 2019 and proved to be very effective in diabetic patient type 2, type 2. And these are the family of empagliflozin, dapagliflozin, and canagliflozin. These inhibit glucose reabsorption from kidneys, facilitating loss of glucose in urine, have lower side effects than the other drugs. They are neutralizing agent, do not cause any weight gain, do not cause hypoglycemia, and single use only per day. This is more practical. Minimal side effects are recorded for this category of drugs, which is urinary infection, may be a concern. These drugs are proved to be renoprotective. It's can be used in diabetic patient with estimated GFR up to 30 and more. Up to 30. That means you can use these drugs in type 3 chronic kidney failure and diabetes. As you see here, it decreases rates of heart failure, decreases nephropathy, and decreases cardiovascular disease, and do not have so much side effects. And the American Diabetic Association admit this medication in 2019, as I said earlier, for patients with type 2 diabetes and chronic kidney disease. Consider use of sodium glucose co-transporter 2 inhibitors or glucagon-like peptide. We are going to come through this medication also. Glucagon-like peptide or GLP-1 analog. It's a subcutaneous injection. The family including excitinide, liraglutide, and these are incretin hormones are released by the gut in response to oral nutrients. They increase blood-induced insulin secretion, but are quickly degraded by enzyme called dipeptidyl peptidase. And there is another category including this dipeptidyl peptidase inhibitor. This category of drug, the GLP-1, causes weight loss and used in patients with comorbid obesity with high body mass index, are forbidden in case of pancreatitis, which is a minority of people complain of pancreatitis from using hypoglycemic agents. Glucagon-like peptide receptor agonists shown to reduce risk of chronic kidney disease progression, cardiovascular events, or both. Okay, these are the updates, which for patients with type 2 diabetes and diabetic kidney disease, consider use of SGLT2 inhibitors in patients with an estimated GFR more than 30, and this is advanced kidney injury. This is type 3B class. As you know that chronic kidney injury is divided into 4 stages, starting from estimated GFR 90 and ending with 50 or less, which is the end stage renal disease. Until class 3, we can use this agent safely in diabetic patients, and particularly in those with more than 300 milligram albuminuria to reduce risk of chronic kidney disease progression, cardiovascular events, or both. In patients with chronic kidney disease who are at increased risk of cardiovascular agents, and here comes the role of GLP-1. Use of glucagon-like peptide-1 receptor agonists may reduce the risk of progression in albuminuria, cardiovascular events, or both. As I tell you earlier, both drugs are contribute to controlling hemoglobin A1C to reduce it by 1 every 2.5 to 3 months. And as we said, that hemoglobin A1C is an indicator and correlated with cardiovascular disease in diabetic patient, as well as SGL2. They are correlated with protection of renal function in diabetic patient who has already have deteriorated renal function. So these 2 categories are promising medication in this field. Then by the end of this, we are come to take-home messages. Now we have therapeutic tools. The 2 categories of drug, they are promising. They are doing well in this field, protecting cardiovascular disease, protecting renal function to be deteriorated, not to be deteriorated. And the other thing, the nephroprotective effects of SGLT is seen with different drugs of the same classes. All the class are renoprotective as well as cardioprotective. Is highly significant and of about the same magnitude, indicating the class effects. SGLT are more effective in maintaining loss of kidney function than GLB. GLB is more specified in maintaining cardiac function. Diabetic patient with MI, with systolic dysfunction, with any cardiac disease, valvular lesion, GLB is preferred than SGLT. And the vice versa. Diabetic patient with impaired kidney function, SGLT is preferred for GLB-1. Still, regular exercise and diet control still play a role. And this is important, as you know that we have to maintain good physique, good mobility, ongoing with medication, going with receiving medication and regular medication. Chronic diabetic patients have to avoid contrast-based tests as much as possible as we talked earlier, contrasts as one of the causes of the renal impairment, acute kidney injury in most non-diabetic patients and diabetic as well. Regular checkup for kidney, heart, and liver function is fundamental. We have to check up. In addition of this, kidney function, heart function, liver function, we have to have ophthalmoscope. We have to check lower limbs of diabetic patients. For other complications, we have to check for peripheral neuropathy. We have to check for wounds. We have to address tools that help protecting patient food from injuries and so on. Before any procedure or new treatment, patient must declare his diabetes and medication. Because of interaction between drugs, because most of treatment given for infection or for pre-operation period or post-operation are affecting kidney function. So part of maintaining this is to declare, is to tell the hospital, to tell the doctor that have diabetes and I'm receiving this medication as a treatment. Also, tight control of diabetes and organ function are inversely proportionate with good survival and better outcome. Earlier, they are talking about that whatever the case, whether you are controlling diabetes, you are doing exercise, you are taking your medication in time, and so on, complication will occur. But this changed nowadays. As well as you control your diabetes well, you protect yourself well, you are doing follow-up checks and avoid things that may harm you as a diabetic patient. This will participate in good life expectancy, will minimize mortality and morbidity in diabetic patient as well. By the end of this, we have a clinical scenario, short one, just to summarize the lecture in few words. This is a 62-year male come to see for diabetic review. He has had type 2 diabetes for 8 years. Duration here is more important as complications are related with duration of diabetes. We are talking about more than 5 years in type 2 diabetes and more than 10 years in type 1 diabetes. Complication may occur. He had an acute MI 6 months ago. As I told you here, type 2 diabetes are associated with micro and macrovascular complication. So this is expected acute MI. He is taking metformin 2 grams daily. Metformin is a known anti-hypoglycemic agents. Sitagliptin, which are talking about, is a GLT-1. Atorvastatin for lipid control, daily aspirin, Blavex, captopril for controlling blood pressure, metoprolol as well. We have an obese patient here. BMI is 32 kilograms per meter square. Blood pressure is 140/88. Hemoglobin 1AC is expected to be like this. As we speak earlier, hemoglobin A1C should be less than 7 and less. Estimated GFR is 50. Is 50. Less than 60, this class 2 or class 3A. Triglyceride is high as well. High density lipoprotein is low. Low density lipoprotein is 60 milligram per deciliter. So in this case, we have comorbid patient, we have cardiovascular disease, we have obese patient, and other indices of lipid profile disturbances. Here, 24 urinary albumin excretion is 400 milligram. We have also non-proliferative diabetic retinopathy. Echo shows mild to moderate left ventricular systolic dysfunction, and this is cardiac affection in this patient. This scenario is expected and seen everywhere you go and meet a diabetic patient. So Here the question, how would you modify this patient treatment? These are the choices we have. Adding glycoside in this patient will make the BMI more worth, as glycoside is associated with weight gain. Basal insulin as well. Here, sitagliptin DC and add liraglutide, they are same in controlling renal and cardiovascular complication in this patient. So the answer will be, and add empagliflozin, which is SGLT2 agent, which is coincide with this patient renal function test, as estimated GFR is 50, only 50, and with the cardiovascular disease and other complications. Okay, I'm happy to having you with me here for this short time. Thank you for listening, and thank you. See you inshallah in another lecture.
شكرا دكتور مازن على المحاضرة القيمة. مايك مفتوح للجميع لأي سؤال. أي سؤال؟ طيب شكرا لكم جميعا.